Hi everyone, this is Sudhir Pillai. I work at the Water Research Commission. Our moderator Eva Mary is here, and so what she'll do is she'll give a bit of an introduction to herself and give you some details of the session. This session is focused on COVID-19 in sewage with a developing country perspective and what we've been doing. So I'll let Eva introduce herself and what she does. She's going to give you a bit of a breakdown of the FSM Alliance and the FSM Conference, which most of you would know about. And so, Eva, you can go ahead and start and introduce yourself.
Yes, thank you, Sudhir. Hello, good day all. Welcome to the 30th SuSanA online meeting. And my name is Eva Mary. I work for the FSM Alliance, and I will be moderating the session on sewage testing for COVID-19. So briefly, while we get all settled, we have an upcoming conference, FSM 6, which is to be held between 31st of May and 4th of June 2021 in Jakarta, Indonesia. This conference is convened by FSM Alliance, which is a member-based network to support the organizations and individuals working in FSM. So the FSM 6 call for abstracts is currently open until the 31st of August, and we have 4 themes towards the call for abstracts, which is one being gender equality and inclusive sanitation service level, 2, the service and delivery for low-income communities, 3, role of FSM actors in sanitation, and 4, which is a poster track for the applied research. So I welcome everyone who would be interested to send in the applications or abstracts for the conference until 31st of August. Thank you. So if you're all here, I would briefly go over the general housekeeping rules. So I would first of all request everyone to mute their mic if it is not muted, which I see everyone has already muted, so good. All the questions and comments will be taken after the presentation by each speaker. You can use the hands up button to indicate if you have a question and you'll be invited to speak. The session will be recorded and the presentations will be made available by the end by SuSanA. So if you're ready, I think we can go ahead and begin the first presentation of this session. So this first presentation is by Dr. Sudhir Pillai of Water Research Commission of South Africa. Dr. Pillai's presentation is on developing a COVID wastewater surveillance protocol, lessons from South Africa. It will showcase an African-based approach for using sanitation waste as a potential epidemiological indicator for COVID-19. The presentation will focus on testing and validation of a sampling protocol for raw sewage and settled primary sludge, and testing and validation of the virus extraction and analysis protocol. The process will also cover, the presentation will also cover an epidemiology strategy for non-sewered sanitation that will begin in 2020. Over to you, Sudhir.
Hi everyone, thanks for joining us, whether it's the morning, afternoon, or night for you guys. Yeah, sorry, we got cut off a bit. South Africa has a bit of a power struggle at the moment, so we just had our backup energy come back on. So the session was about a developing country perspective on COVID-19 and what we're doing in South Africa. We decided to go through a phased approach and to develop this detection of SARS-CoV-2 in sewage as a surveillance tool. So I'm going to just go quickly over some of this. Our background, COVID-19, most of you know this, and most of you understand that the main route of virus transmission is through patient respiratory drops. There's a lot of science that is continuously progressing with regards to possible detection and transmission routes. Some of the data suggests there might be other routes of transmission besides respiratory. And so far, the virus has been detected in feces and urine of infected patients. Aerosol transmission still needs to be validated. And viral DNA has been detected in the wastewater around the world, and those are some of the countries that you can see where it's been detected. Now, the detection of the virus does not mean it's infectious, but what we can use is the genetic material to understand surveillance and how the disease flares up. So basically, hotspots. This is if you look on the left, this was a news article. It says COVID-19 was already detected in Italy in December based on sewage analysis. So that gives you an indication of when the virus was shed in by a patient or someone that was infected. If you look on the right, this was a journal article produced by the Yale group. Now, if you look at the little circle part of the graph there, it's showing hospital admissions and the viral RNA load in the wastewater, and you can see those graphs are very closely correlated. What this means is that by measuring what's in the wastewater, in this case it was this municipal sludge, you can correlate this with hospital admissions, and they're very closely correlated. What does this mean? You can see sometimes there's a second wave of infection, the third wave of infection. This can be your surveillance tool and your hotspot mapping. So you can determine in a specific area where this disease is flaring up by doing analysis of your actual sludge or your wastewater. This is not supposed to replace individual testing, but it does give another tool in the arsenal in how we manage flare-up of this disease and outbreaks. The standard technique that they use is real-time PCR, and the reason I'm explaining this is when you start looking at some of the graphs of what we picked up, there's an important value they call the cycle threshold. What this means is now not like your traditional graphs where you find a higher number is equal to more virus. What this graph will show you, and when I show you later, is that if it's less than 30, you're having strong reactions, but if it's over 38 or 40, those are weak reactions. So just bear that in mind when I'm presenting some of the graphs. We've started as a national program in South Africa, a surveillance program to pick up RNA, COVID-19 RNA signals in wastewater. And the reason we're doing this is to complement our analysis, our current individual testing program. Can we use wastewater within South Africa to determine heat maps of the virus? We've also set up a COVID-19 page where we have a list of different type of reports and knowledge projects, fact sheets. How do you handle viruses in wastewater? Various different things, and also in different languages. And we thought it was important to set up this little knowledge hub and COVID site while the information is hot. Just an example, we have big scientific reports and we have more smaller knowledge products. So maintaining good hand hygiene, water quality sanitation and the management of the disease. You know, death and burial was something that we also considered in the time of COVID. What are the health risks and environmental risks? So these are just some of the products we put up, and we put this on our website. Our surveillance program, we're carrying out in phases. And as I said, the reason we're doing this was to establish and track COVID-19 cases and mapping in hotspot areas. Now, many of you all are involved in water and sanitation, so this is not new to you. So whether it was a cholera outbreak or you'll see in the other presentation, they make use of polio. This type of epidemiology hotspot mapping is not something new to the water and sanitation field, but it's something we'd be looking at and applying. So our program has been undertaken in 3 phases. And this is what we're presenting today. I'm presenting the first phase, which is our developing the tools and the methodology for proof of concept. Our second phase will look at national pilot scale monitoring. Usually our established protocols we established in the first phase, and our third phase will look at a national watershed surveillance program. We're also looking at our wastewater program be complemented by a non-sewered sanitation surveillance program. Many of you guys, if I'm looking at the participant list, come from developing countries, and developing countries are not 100% sewered. That's the reality of the situation in developing countries. The degree of sewered or non-sewered depends on the city and the country. It's very location based, but we also want to look at, can we, for these non-sewered, specifically high density areas, can we develop a tool that can have the same type of surveillance benefits? And so we're on the way of developing that specific tool, and I'll give you a bit of an update later on. As I said, our proof of concept was about establishing the methods, so testing and validation of the sampling protocol. This is very important for both sewage and settled sludge. Testing and validation of the virus extraction analysis protocol. So various testing and validations, basically protocol validation. Are we using the right methodology for quantification of the viral loads? Our sampling methodology for our first phase, we took 3 different locations, so 3 different provinces in South Africa, 3 different wastewater treatment plants. We want to know whether grab sampling or composite sampling would work. So grab sample, you take a once-off sample. A composite sample would be a 24-hour sample for that specific plant, and we wanted to compare the both. We're also primary sludge samples, and we've been doing, just for the proof of concept stage, just to get the methodology right, some weekly samples. We're also looking at sewage from hospitals, because most of the cases are coming from or be concentrated around hospitals, and surface water sampling. Our virus recovery methods that were used was using polyethyl glycol, so we used that, and the skim milk. The reason for the 2, we wanted to just test the different efficiency methods for viral concentration. There are other methods, and you might find these methods presented in the next presentation, but we wanted to try these 2. Skim milk is a more, I would say, a more economical technique for viral recovery. The Mengo virus is just something that was used as a control, and these were samples that were taken. We took 1 or 2 liter samples. As I said, 2 different methods, the PEG method and the skim milk method. The skim milk method appears more less laborious and easier to undertake. So these were the 2 techniques that we used. So just to give, I'm just going to wait a bit just to give you people time to read some of the details. This presentation will be made available through SuSanA. And as I said, the CT values, a high CT value does not mean there's more virus. The lower one means more possibility or strong correlation with the virus. So we look at our 3 different areas. We can see the difference between our grab samples and our composite samples for the different areas. The grab samples, if you look on your right, were taken during peak flow times, where the composite sample was 1 over 24 hours. I'm not sure what happened to my presentation, but let me start it again. Sorry about that. And if you look at our comparison between our PEG and skim milk recoveries, more or less similar results were taken. But if you look at the bottom, some of the gene expressions or the gene amplifications, there was more in the milk than actually the PEG. So there are benefits in using the skim milk approach. As I said, or just trends and values in our composite and grab samples. It can vary in the area. As you can look at area 3 was the same type of wastewater treatment plant, but the type of CT value you're actually getting can be quite different. You can also notice the same trend for area 1 composite sample and the grab sample. So from my own perspective, I think a grab sample has been proven to be much better, I think, because you're picking up during the peak hours when people are using the toilet facilities. As I said, we're also developing a non-sewered surveillance tool. So, this is a aerial photograph within South Africa. It's not two different photos. It's actually one area. So on the left, you can find the nice houses, sewer-based approaches. On your right, very high density, non-formalized areas where there's probably no sewer connections. And so our surveillance tool will be also looking at these areas. One of the reasons we want to do this is because non-sewered areas, typically in a developing urbanized community, they're very closely, densely packed. There's shared use of toilets and ablution facilities. Social distancing in those contexts is quite difficult. One of the challenges with non-sewered approach or surveillance tool is where there's a sewered area within a developed country, you can get a big population size and predict the outbreaks. Non-sewered areas is where do you sample? Where are you sampling the shared toilets facilities? Are you sampling the sludge from the toilets? Are you sampling the pools of water that are left around? And so we're developing that methodology and framework for this specific non-sewered tool. Results to date, and I can share some of this, is that we have detected genetic material within the non-sewered material domain. So when those results come out and we formalize and we go through it, we were willing to share this later, even through SuSanA Group. As I said, there is a case for non-sewered sanitation surveillance, is 2 billion case. These photographs are from South Africa, but I'm sure other developing worlds have the similar challenges with these high density areas. And it's important. We want to see if we can develop a non-sewered surveillance tool, especially for these areas, because it's so densely packed, and it's about predicting your second or third flare-up of COVID-19. As I said, some of the possible hotspots we're looking at, densely populated settlements. We wouldn't go to a rural area where there's space and there's space between houses. We're looking at densely populated areas where there are space constraints. Well, there'll be frequent person-to-person contact, shared use of facilities, and just about, yeah. So some of our concluding remarks is that we've demonstrated the proof of concept. We were able to extract the virus, and we showed positive gene amplification at 3 of our wastewater treatment plants that we sampled. We're going to look at hospitals and surface waters, and also within other non-sewered domains. Well, as more data comes processed and we move into a second phase of the study, we're going to look at having these type of reporting structures incorporated into national COVID-19 responses. So that's the end of my presentation. I'd like to acknowledge the University of Pretoria, Water Lab, and CSIR within South Africa for undertaking a lot of this research, which we funded. Eva, I am complete. I'll leave it up to you.
Yeah, thank you, Sudhir. So if I can invite everyone, if you have any questions, please use the raise your hand button, and I can call you up. So the questions. Okay, I guess we're still having people joining in. So I'll just jump in here. Oh, wait, we have Sanjeev Shekhar. Yeah, please go ahead, Sanjeev Shekhar. Yeah.
I think I missed part of the presentation, but then whatever I ended up hearing was absolutely interesting and also so exciting. My simple query is that wastewater surveillance found the SARS CoV-2 virus before the reported cases, at least in the Netherlands, and probably in also some other countries. So therefore, the evidence which actually emerged was that environmental testing might complement clinical surveillance to detect cases of COVID-19 cases. Very interesting. But then my actual question is that how sensitive is the test would like it to be, or in other words, what percentage of local population has to be affected for the virus to be detectable with some sampling protocol? So I would like these speaker to comment on it if I've been able to make my point clear to him. Thank you.
Sudhir, you want to jump in and answer that one?
Just to clarify, he just wants. Can I ask for more clarification on that specific question?
So I will repeat. How sensitive is the sewage testing, or in other words, what percentage of the local population? I mean, I'm talking about the catchment which a sewage, treatment plant is actually catering to, has to be affected for the virus to be uh, detectable with some sampling protocol. When by estimating the amount of virus in the sewage, can we also kind of predict the extent of infection, the prevailing infection in the catchment the STP is actually catering to? I hope I'm clear now.
Yeah, you are clear, and
Yeah,
I think
thank you.
I'm just going to go back. I know you missed the first part of the presentation, so I'm just going to go back to it. The reason why we're developing this, and I'm showing you results from around the world and why we're also going on this route. And so I will be quite fast with this. If you look at the specific slide, if you look on your right, where it says there's an article there, and you can see in that article there's a blue shaded area. That graph is showing the viral RNA in your wastewater and your wastewater sludge. And the other part of the graph is showing hospital admissions. Now, if you look at the actual graph and trends, your hospital admissions is mirroring what's been found in the sludge. You can also look at the bottom. New COVID-19 cases, and you can see the viral RNA and new cases are mirroring each other. So for that specific catchment, for that specific study, and we're not saying that it's applicable to every single geolocation, but the results are showing that you can match it, and this is what we're trying to do at the moment. I hope that answers your question.
Yeah, thanks very much. I'd actually missed that. Thanks very much. Thanks.
We have the question in the comment by Arna. I'm going to just read out the question. What is the reaction from the political level? And I would also like to add on to it, if in case, what has been the effect, or like that has the test been also being doing side by side with the current in South Africa, like the lockdown effects and the spread of the presence of the COVID vaccine in the wastewater with respect to, has that been correlated at all? I mean, what is the outcome from that?
Okay, so from political level, we have buy-in, and our results. We do in continuous discussion and partnership with some of our disease centers for monitoring our disease outbreaks in the country. So political will is there. It's one of the tools in the arsenal that can be used, especially for flare-ups. South Africa at the moment has just come out of its major peak. Samples have been collected. We can store them for -80 for a while. And so a lot of our program, we just managed to get during our peak period. So political will is there, especially if we can map out the heat maps where the diseases are breaking out. So that's the important thing. There is coordination between the various departments. They know about it. And yeah, so as I said, we're coming out of our peak. We're just going down, but most countries are showing a second flare up, and so this is where having such a surveillance tool becomes necessary.
Thanks, Sudhir.
Sorry, did I cut someone off?
I was just saying thank you.
Oh, right. Okay. I see another question by Jigisha on what should be the sampling protocol. I think it was mentioned in the presentation, but maybe for the new joinees, do you want to just have that put up on the slide, maybe, Sudhir? That'll be helpful. I hope that will, yeah. And then we have another question by Olufemi on if you could elaborate on the sensitivity and the specificity of the results. Yeah.
Yeah, so with the non-sewer thing, it's a bit more challenging because, and I'm not saying sewer is easier, the sewer is also quite difficult. You have to get your sampling protocol right. So let me answer the second question first. We established our program, our national program, in phases, and the first phase was to develop our methodology specific to our country and our country needs and what we have available. So it was about going out and just ensuring that we can pick up the virus at appreciable levels, you know, and then from there we can move into a surveillance type of program, because if you weren't picking up enough of the virus during our own peak, as a surveillance tool, it wouldn't make much sense. So that was our first wave. We picked it up. Now it's about extending the program and to see how the results correlate. Also, once we start linking the stuff to hospital admissions, new cases, then that's when the benefits come through. And so that part is ongoing at the moment. And I think around the world, it's a similar scenario. With regard to the non-sewered surveillance tool, this is quite a difficult and challenging part, because what's non-sewered in South Africa is quite different to what's non-sewered in India, or what's non-sewered in Uganda, because our systems are dry. You know, the type of drainage system that is available per country is going to be different. So in South Africa alone, we're looking at within our specific non-sewered environment, and those of you who work in the wash sector, you would know what's non-sewered is quite diverse. So for us, it's about our sampling protocol. You must be able to detect enough of the virus. How you sample is very important. Let's say if you at a hand washing station that's shared by a lot of people, and a lot of people are washing their hands in the soap and they're using soap and disinfection, how would that affect your RNA signal is important. So this is our first part, is establishing, do we get enough of a signal to use this as a surveillance tool? And what we get in South Africa for non-sewer domain might be totally different to what's in Uganda or what's in Kenya or what's in India. And so that type of protocol has to be established within each geolocation. But for South Africa, we're trying to build up our own non-surveillance methodology and technique. Eva, I hope I answered those questions.
Yeah, thank you. We have we're going to take one more question before our next presentation. So I think we have one by SuSanA and Josman, and that I'll just read it out. So what is the current status in the non-sewered protocol? What is the current status of development? Is it already ready to be applied or still in the testing phase?
Well, it's still in the testing phase, and our first phase was just to make sure we get enough signal from wherever we're testing. So that's the first phase. Once we establish that, then we go into the more scientific part and the more scientific validation. We first want to test whether there's a strong enough signal to make a case, because if there's not a strong enough signal, there's no point in developing the tools for ourselves in South Africa. Now, as I said, it's quite, non-sewered environment is more challenging because our countries differ so much in how we apply non-sewage systems. So that will have to be formulated within its own country and even site-specific. There's no use developing a surveillance tool if you have 100 people within a community, because individual testing might be actually cheaper. But if you have a very large city with a very large non-sewage community, it makes sense. But this is the things we have to work out in the economics of individual testing versus a non-sewage surveillance tool. But because it's difficult, doesn't mean we shouldn't try. So we're on our way to trying.
Thank you, Sudhir. We'll just go on to our next presentation. Next speaker is Nithya Jacob, a policy analyst and consultant with long experience in advocacy, policy change, and water-related research. His presentation on potential of sewage for predicting COVID pandemic in India will talk of the Indian experience with testing sewage for COVID-19 and the development of protocols based on the work done by different consortia and universities. Nithya, over to you.
Hi, good afternoon, everybody. Is my presentation visible?
Yes, it is.
Okay. So I'm going to talk a little bit about the experience of testing wastewater and sewage in India over the last few months. And it kind of segues nicely from Sudhir's presentation, and there are lots of common issues. So that's kind of nice to know that we're grappling with similar problems on two different continents. So the pandemic was first recognized as such in India in March, and by late April or early May, several organizations and institutions had started testing the inlets of wastewater treatment plants in different cities.
Sorry, Nithya, if I may just interrupt, could you speak a bit louder? We had a request regarding the volume. Sorry, thank you.
Is this any better?
Yeah, much better. Yeah, thank you.
Oh, okay, fine. So just a quick look at what this whole sewage testing thing is about. It is a process that's been around for a while, wastewater-based epidemiology. And it is a method of testing wastewater or sewage for the presence of pathogens, in this case, viruses. It's been used in many countries for tracing polio, as well as antimicrobial resistance. And since March, the Netherlands example that Sudhir mentioned is from March. But since then, more than a dozen European and American countries have used this to trace the pandemic, and quite a few have started moving to systematically monitoring it, to setting up laboratories and monitoring systems and information sharing systems to monitor the pandemic. There are a few steps in this. The first, of course, is sampling. And we'll get into some details of sampling here, the challenges and advantages of different methods. So the Indian example, in all the Indian examples, they've sampled from sewers, from the inlets of sewage treatment plants, and in a couple of cases also from the outlets to see what the impact of treatment has been. Open drains and possibly fecal sludge treatment plants. So the last has not yet been tried in India, even though a large percentage, about 40% of the urban population uses on-site sanitation. Mostly, the testing is mostly done using established methods, usually RT-PCR, and that's because it's the kind of gold standard. It's been accepted by the government, and everybody just wants to follow the accepted method of testing instead of suggesting something new. And that also would make it easier as in for city governments to adopt it as in when that does happen. And then using the test results to predict the pandemic, if the virus fragments are found. And there are equations that have been developed which give a range of probable cases depending on the concentration of the viruses in the sampling. So viral RNA can be detected from COVID patients from about the 4th or 5th day of being infected. And then they continue to shed it in their stools even after 30 days of infection. Like I mentioned earlier, there have been at least 5 known initiatives in India. And they have had the active participation of local authorities, the city government, or a government research organization, or a university, or even the Pollution Control Board. So all these examples have been done along with the government, and this is significant because the government is the main kind of player in the COVID response in this country. Look at a few of the initiatives. In the city of Bangalore, there's a consortium of 5 organizations, 4 Indian and 1 international. They have tested different sewers and open drains for the presence of the SARS-CoV-2 virus. This started in April 2020, and it was a collaboration between a public health organization, a private laboratory, a government hospital, which is now a COVID hospital, and the wastewater and sewage experts, as well as international microbiologists. The consortium had secured permission from the city government to do the sampling and testing, because without that, it's not possible to proceed. And the containment zones, which a list of which is put out by the city government every day, the drains flowing through those containment zones were selected for sampling, and they have detected the virus RNA in all the samples. So there have been roughly about 15 samples that have been taken, and the RNA has been found. This group also wanted to conduct tests from the stools of patients in the COVID hospitals, but the kind of ethical clearances haven't come through yet. And the idea behind that would be to be able to correlate the level of infection with the amount of stools shed by a patient, and therefore to be able to extrapolate what happens in sewage, to be able to determine the concentrations in sewage with the number of, with the possible caseload in a locality. In May, in Gujarat, the Indian Institute of Technology has become part of an international consortium led by Swedish researchers, and they have tested sewage from the inlets of sewage treatment plants. The State Pollution Control Board helped them in this activity, and they found RNA fragments in all samples. Sorry. And they're going to be quantifying the amount of viral RNA excreted and try to extrapolate the number of infected people, much in the same way that the group from Bangalore is trying to do. Chennai, which is another city in South India, the SETI water utility, Chennai Metro Water, collected samples from 5 sewage treatment plants, and RNA fragments were found in 2 of them. They were very keen to expand this testing because they felt that the WBE approach would help to alert a population cluster. And they even plan to develop a protocol with the World Health Organization. However, they were asked to stop the tests a little while, a few weeks after reports came out. And there has been no resumption of this at the moment. Most recently, in another South Indian city called Hyderabad, two government research institutes have recently tested samples from sewage treatment plants, both from the inlets and outlets, and they have found a significant concentration of RNA fragments. So their predictions, only 40% of the city has a sewage system. So they actually extrapolated their findings for the whole city and kind of predicted that about 6.6% of the population of Hyderabad would have at some point in the last month been exposed to the virus or would have been COVID positive. And that's much more than the numbers being put out by the state government. So I think all these examples kind of point to the potential and the sheer range of activities that have happened in India over the last 3 months on sewage testing for the presence of COVID. Again, in Jaipur, scientists from the Bilal Institute of Biotechnology collected samples from 6 STPs and from 2 major hospitals. And they found that the concentration of the virus fragments in their samples was directly proportional to the caseload as reported by the city government. So all this points to the advantages of where WBE surveillance. Research has kind of indicated that this would be 0.014% the cost of clinically testing individuals. So that means, I mean, if you want to test the population of an entire city through sewage, you would spend only a fraction of a percentage compared to what you would spend if you were to test all the individuals using the RT-PCR method. It's much faster than individual testing. It could be possible theoretically to cover an average city's population every day, whereas it's impossible to do that, to do individual testing for everyone every day. It uses established methods, which is accepted by the government and the state governments for testing. And it can be used to project a range of cases in a geographic area based on the concentration of the virus fragments. But there are many drawbacks, and I think Sudhir also pointed to some of them in the South African context. Sewage systems in most Indian cities are highly fragmented and are in various states of disrepair. They are a combination of underground sewers, septic tanks, open drains, pit toilets, and this really complicates the sampling methodology and could also limit the use of WBE. The other challenge is that, of course, you can get a rough geographic area where COVID positive people are likely to be, but you cannot pinpoint the households where they live. And finally, probably the most important factor here is that the bureaucratic and political will to take this kind of testing up has been lacking, largely because the apprehensions of being able to manage the fallout, because the likely numbers to come out of this kind of testing will be far more than what is being being put out by the government at the moment. However, I think there is no doubt, especially among the people who've done this testing in this country and abroad, that sewage testing or WBE has tremendous utility in controlling the pandemic. It is a powerful decision support tool, and it can also help to decide where to test individuals. It can help to predict outbreaks. It can help to determine containment and quarantine zones. City governments or state governments can actually launch mass awareness programs to prevent further spread, or decide which areas of a city or a state to lockdown, depending on the detection of the virus. So based on the 4 or 5 examples that I spoke about, we've prepared a very broad kind of suggested approach, which takes into account the fragmented nature of sewage systems in any given city. So the first thing is, of course, to map and understand the sewage and sanitation system, see whether it's sewered or if it's on-site or off-site, open drains, underground sewers, and then divide the city into smaller geographic areas by the type of sanitation or sewage systems, and then further break each area down into a manageable population size. Thereafter, sampling points would have to be picked up from sewer outfalls from each of these areas. Or if it's a non-sewered area, then it would have to, the sampling methodology would have to follow the kind of schedule and routes of the pit emptiers of septic tanks to be able to collect samples from these suction machines. The sampling would have to be at a set interval, and at least in the Indian context, this random samples, continuous sampling may not be possible, but grab samples could be used to, could be combined into a composite sample. Storage and transportation in the Indian context is challenging because temperature affects the viability of the RNA fragments very quickly, and ambient temperatures at this time in this country are over 20 degrees, and that means that the samples need to be collected, refrigerated, and then transported to a lab, and then tested within a few hours to maximize the usefulness of the results. So to reduce the chances of degradation of the samples. This is kind of like a decision support flowchart for city governments, and essentially divided by whether or not RNA samples are detected. So if they're not detected, then the city governments need to make sure that the area stays green and tests are repeated at regular intervals. However, if samples are detected, then depending on the concentration, decide whether that's going to be a containment zone and whether individual testing is required, or is that going to be an orange zone with some restrictions, and should there be quarantine areas within that, as well as mass contact. And then these tests would have to be repeated at regular intervals, possibly at weekly intervals, to make sure to track any change in the status of these areas. Most crucially, communicating with the public is extremely important. At the moment, most of the communication goes out from the state or the central government, mostly around protocols, do's and don'ts, and things like that. But if there are localized changes in the COVID status, in the pandemic status, then city governments would have to develop communications material and disseminate them through whatever media is available, usually electronic, print, and online media. There is a large cadre of frontline workers in different departments, health, education, sanitation, livelihoods, and various other departments, who could be brought into this kind of communication mass outreach work. There's a strong network of local leaders as well as religious heads, and then there are many community-based organizations and other networks available. All these would have to work together to make sure that the communication that goes out to the public is accurate and timely and does not lead to unnecessary panic, which is one of the apprehensions of testing sewage for COVID. So I'll wind up the presentation with just a mention of a couple of resources. There was a discussion on the SuSanA India chapter in May and June on the potential of testing sewage, and the link is given here. But you will get the presentation along with the link a little later. And there is a network of organizations that has been set up. Over the last 4 months, it's grown to nearly 300 organizations working in the field, working on advocacy, technology, and various other forms of parts of the COVID response. And the website is covidactioncollab.in. At the end, I'd just like to acknowledge that the India chapter is supported by WaterAid, IRC, and the India Sanitation Coalition. Thank you all for listening.
Thank you, Nithya. I would invite the questions from the audience. If you guys have any, please use the raise a hand button. Or you can also alternatively type it out in the chat, and I can read them out to you. So I had just a follow-up question, Nithya, regarding the political will. I know in India there is like the all state and national governments are willing to doing everything they can, but also what about the rural testing? Is there also widespread? Because you mentioned cities, is it also there in the rural areas?
Yeah, Eva, there is a lot of testing in rural areas at designated centers. What actually happened in India over the last 3-4 months was there was a huge movement of people, of laborers from cities back to their villages. And when they actually reached back, they were all tested before they were allowed to travel to their villages. There are designated testing centers in villages for individual testing. I'm not aware of any sewage or fecal sludge testing procedures or systems in rural India. I don't think there would be any. I haven't read about anything. I haven't heard about anything.
Okay, thank you. Yeah. So if anyone has any other questions, okay. Then I think if there's nothing else anyone wants to ask, oh yeah, that is Chikisha has a question. How contagious would COVID-19 be as it would be flowing in open drain areas? Are there any studies on it? I guess it's open to both Sudhir and Nithya, because I think it could be both from African and Indian context. So if both of you could take a jab at it, or yeah.
Okay.
I can go. Oh, Nithya, you can go first.
Oh, okay. Thanks, Sudhir. So the WHO has said that there is no evidence at the moment of the virus has found in sewage or drains being infectious, but it also cautions that there aren't enough studies on this. So there's no evidence of fecal oral transmission of COVID. However, there's a lack of studies. That said, there have been a few reports of COVID virus of the virus being detected in aerosols which happen when you flush toilets or in sewage treatment plants. So again, there haven't been any reports of infections caused by this, but the virus has been detected in the aerosols.
Okay, thank you. Okay, we have a hand by Sanjeev Shekhar. Yeah, please go ahead, Sanjeev.
Just a comment on what Nithya said on that, a following remark, that we got absolutely no evidence as of now that the COVID-19, the virus in the sewage could be infected. But then we've got evidences, I think a large number of studies, at least quite a few I have already, cited in the literature that other SARS virus in the sewage has been found to be potentially infective and have caused infection in the past. There are evidences. Thank you.
Yeah, it's true. Thank you. So what about cases? I know there are many areas, both in South African context and in Indian context, where the sewage is flowing through drains, and which is coming in. So I guess to going back to Jagisha's question, I think, are there any contamination to water bodies then due to this? And has there been testing along that lines also? Yeah, if either of you could answer.
Well, we're busy. We first want to do the wastewater surveillance program, and then we're going to start looking at the water bodies afterwards. As Nithya pointed out, it doesn't mean that you find genetic material that it's infectious. So understanding, there's still a lot of more research to be understood on how the virus survives in different water streams, and at the moment we can only model it according to other coronaviruses that have been studied.
Okay, thank you, Sudhir. We have a question on the comments by Ibrahim. How this method can be used in towns where people use septic tanks, pit latrines, etc., and no sewage system and wastewater treatment plant. Are you referring to Nithya's presentation, I'm assuming, Ibrahim? So I'll give it to Nithya on this. Yeah.
Okay, thanks, Ibrahim. Before I answer that, I'll just add to Sudhir's thing on testing water bodies. Yes, it is an area that we'd like to test, but again, I don't think anybody here has yet gone and started testing rivers and ponds, which are the kind of final receptacles of untreated sewage in India for the presence of coronavirus. There haven't been any reports so far. To Ibrahim's question, it's really hard to kind of figure out the testing protocol for non-sewered systems. So there is a method of emptying septic tanks, both formal and informal, in India. A suggestion was to map the routes and the times of the pit emptying trucks and collect samples from them, which would give an idea of where if the RNA fragments are found, it would give an idea of where infections are prevalent. A few small towns have set up fecal sludge treatment plants or even decentralized wastewater treatment systems. And the inlets of those would be another potential point of testing to be able to answer if there are COVID positive cases in that particular town. But it is problematic. It's much more problematic than testing sewage systems.
Yeah, thank you, Nithya. Okay, so I think we have no further questions from the audience, and now I'd like to thank both the presenters. Thank you, Sudhir, and thank you, Nithya, for very insightful presentations by you both. And I would also thank SuSanA for organizing these sessions, and thank everyone in the audience, wherever you're listening from. You've all been wonderful, and thank you.
Thank you, Eva from Sudhir and the FSM Alliance for hosting and moderating the session. So peace and my regards. Thank you.
Thank you. Yeah, all right.
Thank you, Eva, and thank you everybody for listening in.
Right.
Thanks everybody from the SuSanA Secretariat. Great session.
Lovely. We liked it very much. Thanks very much.